Imagine trying to sail, like a massive, incredibly complex ship across an ocean,
Right.
right? But you've only ever read about it in a library.
Yeah, like you've memorized all the nautical maps, you can recite the names of the currents, but
Exactly. You know the math, but you have never actually felt the wind hit the sails or, the unpredictable sway of the deck beneath your feet.
right, right.
And Sir William Osler, who's basically one of the founding giants of modern medicine, he used a really similar analogy to describe medical education. He said, to study the phenomena of disease without books is to sail on uncharted seas, while to study books without patients is not to go to sea at all.
I mean, it is the perfect encapsulation of clinical practice. You can have all the theoretical knowledge in the world, but until you're standing right in front of a patient interpreting their specific, unique presentation, you aren't truly navigating.
Right.
In clinical surgery, the patient's body is the ocean.
Mm.
And the textbooks, well, they're just the compass to help you figure out what the environment is actually doing in real time.
Okay, let's unpack this, because providing you with that navigational compass is the exact mission of our deep dive today.
Absolutely.
We are jumping into the intense, high-stakes world of clinical surgery. And our primary source material today is the brilliant medical text, Surgery, Clinical Cases Uncovered.
It's such a great resource.
It really is. Our goal here is to decode exactly how surgical diagnoses are made and how treatments are actually executed in the real world. So whether you are a medical student, a young professional, or just someone intensely curious about the human body, we're treating this as a high-yield learning experience.
We are putting you right into the shoes of a surgical detective.
Yes, and that detective metaphor is super crucial. Long before a surgeon ever picks up a scalpel, they have to master the art of gathering clues.
Right. The physical act of cutting is totally secondary to the intellectual work of knowing exactly why to cut or where to cut, or even knowing when to keep the scalpel completely sheathed.
Which is often the hardest part, I'd imagine.
Oh, definitely. And that whole process begins with the absolute foundation of medicine, the patient history, and the physical examination.
Taking a history is so much more than just, having a patient fill out a questionnaire. It's an active interrogation. The symptom is the suspect.
I love that framing.
You can't just accept, my stomach hurts.
Yeah.
You have to ask, okay, exactly when did it start? How fast did it get worse? Who are its accomplices?
And you have to stay incredibly skeptical because the human nervous system, it will intentionally throw you red herrings. The text highlights a really dangerous diagnostic trap called referred pain.
Which is just wild. Explain how that works.
Sure. So referred pain is this fascinating phenomenon where the brain fundamentally misinterprets where a pain signal is coming from. And to understand why, you actually have to look at how a fetus develops.
Wait, really? Embryo development.
Yeah. During development, different organs migrate to their final spots in the body, but they drag their original nerve supplies along with them. So because of that, totally different areas of the body end up sharing the exact same neurological switchboard in the spinal cord.
Oh, wow. So when a signal hits that switchboard, the brain just gets confused about who's actually calling.
Exactly. And the text gives two highly specific examples that every surgical learner has to memorize. First, if a patient's diaphragm, the main breathing muscle, gets irritated by, say, internal bleeding.
They don't feel it in their chest.
Right. They feel a sharp pain right at the very tip of their shoulder.
That is so bizarre.
It's because the Fernania nerve, which goes to the diaphragm, shares a spinal pathway with the skin over the shoulder. The brain is just way more used to getting signals from the outside skin than an internal organ, so it defaults to the shoulder.
Makes total sense. And the second example?
Testicular pain. Testicular pathology can radiate pain upward to the periumbilical region, so right around the belly button.
Which is dangerous, because if you don't know that wiring, you might be poking around the patient's stomach looking for a GI issue while they have a critical emergency further down.
Exactly. Which brings us directly to the physical exam itself. The book is incredibly stern about this. You absolutely must ensure proper physical exposure of the patient,
Regardless of social discomfort.
Modesty has no place in a diagnostic emergency. The text specifically warns that failing to fully expose the groin area during an abdominal exam makes diagnosing a femoral hernia physically impossible.
And a femoral hernia is when a piece of the bowel pushes through a weak spot into the upper thigh, right?
Yeah, the femoral canal. It's a really tight space. The bowel can easily get trapped and strangulated, meaning its blood supply gets completely cut off.
And tissue death starts in hours.
Right. So any temporary embarrassment about asking a patient to expose their groin, it's negligible compared to missing a lethal mechanical obstruction.
And once they are exposed, the tests are sometimes shockingly simple. Like, the book details the cough test. You literally just ask them to turn their head and cough.
Most people associate that with checking for a hernia.
Because the pressure forces the bulge out, right?
Yeah, but what's fascinating here is that the cough test is actually a dual-purpose tool.
Yeah.
It also acts as an immediate indicator for peritonitis, which is peritoneal irritation.
Oh, wow. How does that work mechanically?
So the peritoneum is this incredibly thin, dual-layered membrane that lines the abdominal cavity and wraps around the organs. Normally, these two layers just glide smoothly against each other.
With a little bit of fluid for lubrication.
Right. But if there's a severe infection, like a ruptured appendix, that lining gets inflamed, swollen, and exquisitely sensitive.
And coughing causes a massive pressure spike.
Exactly. That violent spike in intra-abdominal pressure forces those inflamed layers to violently rub together. If a patient gets a sharp, agonizing pain just from coughing, you instantly know the internal lining is compromised.
So you're using mechanical tension as a diagnostic tool. That's brilliant. And if we take that mechanical concept to the surface of the body, there are all these rules about lumps and bumps.
Oh, absolutely.
Like sebaceous cysts. They're super common, but the text points out a strict geographical rule. They never occur on the palm of the hand, the sole of the foot, or the scalp.
Right. The absence of something in a specific area is just as valuable to know as its presence. And the reason they can't form on the palms or soles is purely structural.
Because of the fat layer.
Yeah, the subcutaneous fat there doesn't just sit loosely. It's tightly bound within dense fibrous septa.
So it's basically like a heavily quilted mattress, or like a biological honeycomb where the fat is locked inside these rigid, tiny vaults.
That is a perfect analogy. Those fibrous walls stop the skin from sliding around when we grip things or walk.
Right.
And because it's so tightly compartmentalized, there is literally no physical space for a sebaceous cyst to expand. Anatomy dictates the pathology.
So if you see a lump on someone's palm, you can instantly rule out a cyst.
Boom. Exactly.
But, okay, here's where it gets really interesting.
Yeah.
Sometimes the environment dictates the pathology. The book talks about the pilonidal sinus. Usually that's an infection found over the sacrum, right at the tailbone, caused by ingrown hair. But there is this completely bizarre occupational variant for men's barbers.
It's such a brilliant example. You can find a pilonidal sinus uniquely located in the webbing between the fingers of barbers.
And the craziest part, the hair doesn't even belong to them.
Right. When they cut hair, the tiny, sharp fragments act like microscopic needles. Over time, those foreign hairs just embed themselves into the delicate skin between the barber's fingers.
So their immune system attacks it.
Yeah, it detects foreign organic material, launches an inflammatory attack, and creates a painful, infected sinus tract.
It's literally a microscopic occupational splinter that turns into a surgical emergency.
Exactly.
Now, speaking of cuts to the skin, we have to talk about what happens when surgeons intentionally make a cut and the repair fails. The book calls it wound dehiscence.
A burst abdomen.
Yeah, a surgical incision, completely tearing open. They break it down into preoperative, operative, and postoperative factors.
Because wound dehiscence is almost never just one localized failure. It's a cascading systemic collapse.
Right, like preoperative stuff, vitamin C deficiency.
Yeah, or protein deficiency, or severe jaundice. You need vitamin C to build procollagen. Without it, the mortar between your cellular bricks just crumbles.
And then postoperative factors bring us right back to the cough test. Violent coughing tears the fresh wound apart.
But the operative phase that comes down purely to the surgeon's mechanical technique.
And the text introduces a mathematical formula for suturing called TPN Jenkins rule.
Yes, a very famous rule.
It says that when closing an abdominal fascia with a continuous suture, the length of the thread has to be at least 4 times the total length of the wound. Plus, stitches must be exactly 1 centimeter apart and bite 1 centimeter into the healthy edge.
Right.
But let me push back on this for a second. If you have a 10-centimeter incision, Jenkins' rule says you need 40 centimeters of thread. That seems like a massive waste. Why not just pull the tissues tightly together?
I mean, it does seem totally counterintuitive, right? Until you factor in the biological reality of inflammation.
Good.
You aren't suturing a piece of dead leather. You are repairing living tissue that is about to undergo a massive trauma response.
Oh, right. It's going to swell up.
Massively. The tissues get engorged with fluid. If you suture it tightly with no slack, As the tissue expands, that tight thread loses all its slack. It acts exactly like a wire cheese slicer,
Oh, wow. It would just cut right through the muscle.
literally amputating the repair.
So the thread is essentially acting like a biological bungee cord instead of a rigid zip tie.
Hmm.
That 4-to-1 ratio is a calculated shock absorber.
Exactly. You have to visualize the wound not as it looks on the operating table, but how it will behave 48 hours later.
Okay, so that's localized wounds. But what about massive surface destruction? The text covers severe burn trauma, and the first step is always accurate geometry.
Because assessing the total body surface area affected is literally life or death. It dictates the fluid resuscitation.
Because the blood vessels get leaky.
Right, it's called third spacing. Fluid aggressively shifts out of the vascular system into the tissues. To figure out how much IV fluid is needed to keep the heart pumping, surgeons use the rule of nines for adults.
Dividing the body into multiples of 9%. But there's also a super practical shortcut for patchy burns, the Palmar method.
Yes, the patient's own hand, including the fingers, represents exactly 1% of their total body surface area.
So you just visually map their hand over the burns, but that math only works for adults.
Right, children are not just miniature adults. Their anatomical proportions are vastly different. An infant's head is a much larger percentage of their body surface area.
So you can't use the rule of nines.
No, you have to use the London-Browder chart, which mathematically adjusts the percentages based on the child's exact age.
Okay, so once fluids are stabilized, the surgical team deals with the skin. For full-thickness burns where the skin is dead, they need split-skin grafts. But the text gives a really rigid hierarchy for where to apply those limited grafts first.
Very rigid.
And I want you to explain this because it feels totally backwards to me. The absolute top priority is the eyelids, then the face, the hands, and the joints. Why the eyelids first? If someone has massive chest burns, why start with tiny grafts on the eyes?
Well, if we connect this to the bigger picture of wound healing, we have to look at how scar tissue behaves. Full-thickness burns don't heal with nice, supple skin. They heal via scar tissue.
Driven by myofibroblasts, right?
Exactly. These cells physically grip the edges of the wound and aggressively pull them together. As the scar matures, it forcefully contracts.
Oh, I see where this is going.
Yeah. If a surgeon doesn't prioritize the eyelids, that contracting scar tissue on the face will literally pull the eyelids open and freeze them in a permanently retracted position.
Meaning the patient physically cannot blink or close their eyes. Ever.
Precisely. And without the eyelid spreading moisture, the cornea rapidly dries out, it ulcerates, and the patient suffers permanent, irreversible blindness.
Wow. So the chest wound might be larger, but the mechanical consequence of the face scar is catastrophic. Function dictates the surgical priority.
Save the site first, then preserve the mechanical mobility of the hands and joints.
Incredible. Moving from the skin barrier to the internal environment, anatomy plays some serious tricks on the surgeon here. The section on the acute abdomen is a masterclass in this.
Oh, absolutely.
Let's look at acute appendicitis. The text relies on Murphy's triad. It's a very specific sequence of symptoms.
Right, outlined by John Murphy. It's based on how different nerves respond to inflammation. It starts with central colicky pain around the belly button.
Visceral pain, right?
Yeah.
Vague and poorly localized.
Exactly. That happens as the appendix first gets obstructed. Then step 2 is severe nausea and vomiting.
And step 3.
As the swollen appendix actually physically touches the sensitive inner lining of the abdominal wall, the pain fundamentally shifts. It migrates away from the center and becomes sharp, localized somatic pain in the right iliac fossa, the lower right quadrant.
It's such a clean, predictable narrative. But the human body loves an imitator. What happens if a patient has a flawless Murphy's triad? The migrating pain, the nausea, the tenderness so the surgeon scrubs in, makes the incision. But the appendix is totally healthy.
You immediately pivot. You hunt for a structure known as a Meckel's diverticulum.
And what is that?
It's a congenital anomaly, a small pouch protruding from the wall of the lower intestine. It's an embryological remnant that failed to fully absorb before birth. Most people who have it never even know it's there.
But if it gets inflamed?
It flawlessly mimics the exact neurological and physical signs of acute appendicitis.
And the text highlights a specific case study here that is basically anatomical roulette. A patient had the textbook signs, they go in, find a healthy appendix, find the Meckel's diverticulum, and the true culprit was a piece of tomato skin.
Yes, a tightly rolled up piece of tomato skin had physically perforated the diverticulum from the inside out.
That is crazy. A tomato skin is totally harmless for millions of people.
But for this specific patient, their unique anomaly created a tiny dead-end trap. The skin rolled up into a spear, lodged itself in, and triggered a life-threatening crisis. It really shows how microscopic variations in physical geography dictate the danger.
So what does this all mean? It means clinical practice isn't just a simple flowchart. Surgeons have to constantly adapt to the unpredictable reality inside the patient,
100%.
which perfectly sets up our final takeaway. A story of massive surgical innovation. The invention of the Fogarty balloon catheter.
Oh, this is a legendary device. It revolutionized vascular surgery. Before this, if you had a dangerous blood clot blocking an artery, the standard procedure was an embolectomy.
But that was brutal, right?
Brutally invasive. Surgeons had to slice open the artery and forcefully scrape the vessel walls to drag the clot out. It caused massive secondary trauma to the delicate inner lining.
But the balloon catheter used a totally different mechanical approach.
Right. You insert a tiny deflated balloon past the clot, inflate it with fluid, and then gently pull the balloon backward. It pulls the clot out without scraping the walls.
It's an elegant hydrodynamic solution. But the truly astonishing part is the inventor. Thomas Fogarty invented this while he was still just a medical student.
Which raises an important question, right? You'd assume a breakthrough like that would come from a vascular surgeon with 30 years of experience.
Right.
But decades of experience can inadvertently build cognitive blind spots. You get so used to the complex, brutal procedure that you stop looking for the simple alternative.
Fogarty had fresh eyes. He wasn't burdened by the dogma of how we've always done it.
Exactly. He looked at a brutal problem and engineered a gentle solution.
I love how that brings this entire deep dive full circle. Because, we are all learners trying to navigate Osler's uncharted ocean.
We certainly are.
And since we promised a structured learning experience today, it is time for a quick review exercise for you, the listener, to lock in these concepts.
Okay, question number 1. Based on the embryological pathways we discussed earlier, if a patient presents with a sharp, localized pain at the very tip of their shoulder, but they have zero external trauma, what underlying respiratory muscle might actually be irritated?
Think about that shared neurological switchboard. The answer is the diaphragm.
Good. Question number 2. You're the lead surgeon. Your patient has a textbook Murphy's triad, including sharp pain in the lower right quadrant. You make the incision, but the appendix is completely normal. What specific embryological remnant do you immediately search for?
The great anatomical imitator. You must check the intestine for a Meckel's diverticulum.
Spot on.
And hopefully you don't find a piece of tomato skin poking out of it. We have covered a massive amount of clinical ground today, from the shared nerve pathways of referred pain, to the mathematical shock absorbers needed to suture a wound, to the fluid geometry of burn trauma.
And the ultimate takeaway is that clinical surgery is incredibly dynamic. It demands a rigorous understanding of biology, respect for unpredictable anatomy, and, honestly, the humility to accept that the patient will always be the most complex textbook you'll ever read.
Well said.
Yeah.
Which leaves us with a final thought for you to carry forward. Thomas Fogarty revolutionized surgery while sitting exactly where many of you might be sitting right now in the shoes of a student or a young professional walking the clinic floors.
Yep. He envisioned a simple balloon.
So whether you are studying for boards, analyzing data, or just going about your daily professional life, ask yourself, what everyday mechanical inefficiencies might you be overlooking just because you've accepted them as normal? What small, persistent frustration could be the catalyst for your own breakthrough? Because when it comes to navigating the uncharted seas of human biology, the most powerful instrument you will ever wield isn't a scalpel. It is a curious mind.